Okay, class, it's video 21, muscles of the pelvis. So in this video, we are going to talk about, let's see, we're going to talk about gluteus minimus, gluteus medius, gluteus maximus, tensor fascia lata, and we are going to talk about piriformis and the deep lateral rotators, which are all these guys in here, and the muscles of the pelvic floor. Let's see. So these muscles here, muscles of the pelvic floor, and what else? Oh, and psoas. Let's take off here. Okay, psoas and iliacus. Okay, so that's what's up here in video 21. So let's go ahead and dive in with the gluteals. So starting with gluteus maximus. I apologize, I feel like there's a ton of noise where I'm recording, but I guess my life is a little noisy. Okay, here we go. Gluteus maximus is the first of the gluteal. So the gluteal group, there are three muscles of the gluteal group: gluteus maximus, gluteus medius, and gluteus minimus. So let's go ahead and start with gluteus maximus. Gluteus maximus in your book is on page 528. So let's take a look at this muscle, gluteus maximus. Okay, gluteus maximus is the largest muscle in the whole entire body, even larger than, like, you know, you might say latissimus dorsi is the largest. It looks pretty big, but gluteus maximus is the winner of the biggest muscle in the body contest. So biggest, strongest, massive muscle. The only one that is stronger than it, but it is size related, is the masseter. So if the masseter was the size of gluteus maximus, it would be the strongest muscle in the body. But gluteus maximus. So let's look at attachments for gluteus maximus. It attaches to the posterior iliac crest, which we can see here along here, the posterior iliac crest. The sacrum, the posterior sacrum and coccyx. We better fade some stuff here so we can see what's going on. Let's fade the muscle so we can see its attachments. Okay, so do we see? Yeah, we can see things pretty well here. Okay, so posterior iliac crest, in through here it attaches. Sacrum and coccyx. So the posterior lateral sacrum and coccyx, meaning the posterior aspect, the lateral aspect, the posterior lateral sacrum and coccyx. What else? So those are the attachments in bold. It also attaches to the sacrotuberous ligament, which we'd have to show that, wouldn't we? So the sacrotuberous ligament is right here. Can I indicate it through it? Let me get rid of this. Here's the sacrotuberous ligament. So sacrotuberous, it's named for where it attaches. So remember, ligaments attach bone to bone, so they help to keep bones oriented to each other the way that they should be, and so they are stabilizers of joints. And so this isn't a direct stabilizer like across a joint necessarily, but it's, you know, sort of a general stabilizer of the pelvis. So the sacrotuberous ligament, it's named for the sacrum and the ischial tuberosity. So that's where it runs. So the sacrum, you can't really see it right here because it's deep to other structures, but the sacrum is here and the ischial tuberosity is here. So that's the sacrotuberous ligament that we're looking at there. Okay, so that's one of the deep attachments of gluteus maximus, is the sacrotuberous ligament. And also the thoracolumbar fascia. Do you remember that stuff? The thoracolumbar fascia, that's this stuff in through here, this strong stabilizer of the low back. Okay, so all of that is stuff that gluteus maximus is attaching to. For its proximal attachment, its distal attachment is the IT band. We haven't talked about that guy yet. The IT band. The IT band is, so IT stands for iliotibial. So the IT band is this strong band of fascia that is closely related to the gallbladder channel. It runs from the ilium, so here's the iliac crest there. It runs from the ilium down to the tibia. So, well, essentially, yeah. And so it, it covers it goes over the lateral aspect of the pelvis, goes over the lateral aspect of the thigh, so the femur, but then it attaches down here at the tibia. So iliotibial band or iliotibial tract is sometimes called. There you can see its attachment to the tibia much more clearly here. Okay. So it's a strong lateral stabilizer, the IT band. A lot of people have really tight IT bands. It can be problematic, especially cyclists. But anyway, we're seeing a muscle here though too. This is tensor fasciae lata, which we're talking about in this video also. So tensor fasciae lata, if I get rid, or maybe if I just fade tensor fasciae lata, anyway, no, it doesn't show it really well. Let me get rid of it and see what things look like here. If I get rid of it, it looks like I get rid of the whole IT band. Okay, so, okay, but I guess the point is that tensor fasciae lata is a muscle that also attaches to the IT band, and but it is not the IT band itself. So the IT band is kind of underneath there. Okay, so gluteus maximus, back to gluteus maximus. Okay, so we can see I didn't finish its distal attachment. So the IT band is one of its distal attachments that we can see right here. And then deeper, it goes down here to attach to the femur. And where does it attach on the femur? To the gluteal tuberosity of the femur. And that, my friends, is what the gluteal tuberosity is named for, is that gluteus maximus attaches there on the femur. Okay, so actions of gluteus maximus. So gluteus maximus being a big muscle that spans the hip joint. So again, if we get rid of a bunch of muscles here, and here we can see the hip joint, right? It's down deep here. This is where the head of the femur is getting together with the acetabulum of the coxal bone. So if we remember that spot, and now we add muscles back on, so here was that spot. So there's the hip in relationship to gluteus maximus. So that means that it crosses the hip posteriorly. So it's going to act on the hip from behind the hip, but also it crosses the hip superiorly and inferiorly. Okay, so we're going to see a wide variety of actions happening here in this muscle. So actions for gluteus maximus, it extends the thigh at the hip. So like if you're in a squat position and you stand up, or if you're sitting in a chair and you stand up, so sitting or squatting, the hip would be like this, or even if you're squatting, it might be like that. So that would be in a flexed position, and then gluteus maximus works to extend the hip. So so like if you're walking upstairs, if you're hiking, and you put your foot up on the next step up, you've done hip flexion, and then when you put the weight on that foot and elevate your entire body, that's gluteus maximus doing hip extension. So hip extension, very strong action for gluteus maximus prime mover in hip extension. It laterally rotates the thigh at the hip, which we can probably imagine that happening, right? If it attaches here and it attaches here, if it's going to rotate the hip, it's going to rotate it around like that. So lateral rotation of the thigh at the hip. The flip side of lateral rotation, which we're going to look at when we see the deep lateral rotators, is imagine that leg is planted. You're walking along, and this right leg is planted. So you're standing on it, and then you decide to. So this is your right leg. You decide now to turn to your left. So you turn your whole body around to the left. The way that you do that is by laterally rotating the right hip, and so that's like the reverse mover action of lateral rotation is called contralaterally rotating the trunk. Okay, so but main thing, hip extension, lateral rotation of the hip, abduction of the thigh at the hip. So abduction, remember, is this action, so moving the thigh out away from the midline of the body. And so it's going to be these fibers up here that are going to do that action. When they shorten and pull toward their center, they're going to abduct the hip. But look what happens when the hip abducts. These fibers down here need to lengthen to allow that to happen. Therefore, if the hip is in an abducted position, so say it's, oops, ooh, pen, not turn the guy. Okay, so here's the hip, and if it's out here, if the thigh is out in this direction, and now we want to, so we've done abduction. So in doing so, we've elongated these fibers, and so now we want to adduct the hip. These are the very fibers we're going to use. So again, if the hip is in this position and we want to move it like this, then these fibers here will pull toward their center and will adduct the hip, adduction. So gluteus maximus, because it crosses the hip above the hip and below the hip, it can both abduct and adduct. So abduct and adduct the thigh at the hip. And our other action here for gluteus maximus is posterior pelvic tilt. So posterior pelvic tilt is when the top part of the fiber pulls down when this leg is planted. So in other words, the leg isn't going anywhere, but we're gonna posteriorly tilt the pelvis. In other words, we're gonna tuck the tailbone under. And so we're gonna pull these upper fibers down toward this attachment here. And that's gonna be posterior pelvic tilt. Okay, so that is gluteus maximus, big, strong muscle, big mover of the hip. Now let's look at gluteus medius and gluteus minimus. So it'd be handy if we could think of all of the gluteals as one muscle group. However, I mean, they are, of course, they're all called the gluteals, but functionally, gluteus medius and gluteus minimus and tensor fascia lata, which is not one of the gluteals, they function more as a group. So gluteus medius, we'll talk about actions of gluteus medius, gluteus minimus, and tensor fascia lata all together here. So first let's take a look at where gluteus medius is, and then gluteus minimus is going to be directly beneath it. So gluteus medius, so meaning the middle of the three gluteals, it attaches to the external ilium, which we can see here. Okay, so it kind of attaches to this whole aspect of the ilium and through there. And with it faded like this, we can see gluteus minimus right here too, which also attaches to the external ilium. But just, you know, it's deeper and a little farther down. Then both of those muscles attach to the greater trochanter of the femur. So here's the greater trochanter. Well, here's the attachment right here. The greater trochanter of the femur is here. And here's gluteus medius. So the greater trochanter, let's get rid of a few of these muscles so we can see the greater trochanter better. The greater trochanter is a big, this is a big attachment site. There are a lot of things that attach here. This is the lesser trochanter, just as a reminder. So gluteus medius and gluteus minimus are the first muscles that we're seeing attaching to the greater trochanter. If you're wondering what these guys are here, they're bursa, and those bursa are little fluid-filled sacs that help to cushion various places that rub. And so like where muscles attach to bones, oftentimes underneath there's a bursa. That's what those are. And they're just showing up because I have connective tissue showing. Okay, so back to medius and minimus. Here's gluteus minimus, and here's gluteus medius. So, so they both attach to the external ilium. They both attach to the greater trochanter of the femur. Let's fade medius again so we can see minimus under there. See minimus. Deep to medius. Okay, so now let's look at tensor fascia lata, and then we'll put actions together for all three of these muscles. So tensor fascia lata is here. Tensor fascia lata. So the name of this muscle, tensor means, a thing that tenses, in other words, a muscle. Fascia lata refers to the lateral fascia, meaning the fascia that runs on the lateral aspect of the thigh, meaning the IT band. So tensor fascia lata is the mover or the muscle of the IT band, and we'll often abbreviate it TFL, tensor fascia lata. So here it is. Its attachments are the anterior superior iliac spine here. Remember what other muscle we've talked about that attaches to the anterior superior iliac spine? It's our friend. Oh, can I indicate our friend here? It's our friend sartorius attaches there. So here's tensor fascia lata. It attaches also at the anterior superior iliac spine and the iliac crest. And so that's its origin, or that's its proximal attachment. And then its distal attachment is the IT band, which we can see here. So its fibers are going to kind of blend in with, in a sense, the fibers of the IT band. So tensor fascia lata and gluteus medius and gluteus minimus act together very much like the deltoid of the hip. So the deltoid, remember the deltoid muscle up here, one of the very first muscles we did oh so long ago. Here's our friend deltoid. Deltoid, remember how it has 3 sets of fibers. It had anterior fibers, posterior fibers, and middle fibers. And when all 3 fibers worked together, they did abduction of the shoulder. But then when we isolate anterior fibers or posterior fibers, then we have different actions, and we actually have opposing actions. And that's exactly what we see here with gluteus medius, gluteus minimus, and tensor fascia lata. So all 3 of these muscles, when they're working together, they do abduction of the hip. So that's one action that they have. So that's when all the fibers are working together, is abduction of the hip. And I think you can imagine that, right? They're these very lateral hip muscles, and if they're going to contract, the hip is going to go out like that, abduction of the hip. So we're going to pull on that greater trochanter, or in the case of the tensor fascia lata, we're going to pull on the IT band and abduct the hip. So that's when all fibers are working together. When we isolate out posterior fibers, now there are no posterior fibers of tensor fascia lata, so tensor fascia lata only comes into play here when we're talking about anterior fibers of medius and minimus. But posterior fibers of medius and minimus back here, and let me show, let me get gluteus maximus out of here, and let's fade it so we can see minimus too. So posterior fibers of both of these muscles in through here, when they contract, they are going to do extension of the thigh at the hip, this exact same actions as deltoid, except it's on the hip. So posterior fibers do extension, posterior fibers do lateral rotation, and posterior fibers do, let's see, there's something else I'm forgetting, right? Extension. That's it. Okay, so it's just that they do abduction together also. So all the fibers together do abduction, and then when we isolate out posterior fibers, they do extension of the thigh at the hip and lateral rotation of the thigh at the hip. Now, of course, there is the flip side of all of that. That lateral rotation of the thigh at the hip when the leg is planted is contralaterally rotating the trunk, and extension of the thigh at the hip, again, when the hip, or when the leg is planted, is posterior pelvic tilt. So there's that too. So posterior pelvic tilt, moving it down like that. Okay, so those are the posterior fibers. The anterior fibers of medius and minimus, which are going to be right in through here, plus tensor fascia lata here. Anterior fibers are going to do hip flexion and hip medial rotation, and then an anterior pelvic tilt also, and an ipsilateral rotation of the trunk. But I'm not so worried about you knowing those. But part of the point here, though, is, so keep in mind that that these muscles are like the deltoid. So posterior fibers do extension and lateral rotation, anterior fibers do flexion and medial rotation, and when we put all the fibers together, we get abduction happening, and then we get the anterior and posterior pelvic tilts happening also. And also we could get horizontal adduction, horizontal abduction, but those are not listed in the book, so that's fine. However, so my point is here that I'm trying to make is that these are big lateral stabilizers of the hip, all of these muscles together. And so one of the ways that you can show yourself how much these guys stabilize the hip is by standing on one leg. So what happens when you stand on one leg is the natural tendency, if you have all of your weight on one leg, is for the pelvis to collapse down on the other side. But that doesn't tend to happen if you stand on one leg and you work on keeping your hips even. What's happening while you do that is these muscles, gluteus medius, gluteus minimus, and tensor fascia lata, are working. They are contracting here to essentially counter this tendency of gravity pulling the pelvis down on the side that you're not standing on. And so that they have a major stabilization function as far as that goes. So you might think, okay, well, that's fine. That happens when I stand on one leg, but how often do I stand on one leg? Well, actually, all the time. When you're walking, you're almost always on only one leg. And so every time you're walking, each time that one leg is up off the ground, the leg that is on the ground, tensor fascia lata and gluteus medius and gluteus minimus on that standing leg side, they are working to stabilize the pelvis, to keep the pelvis even. Okay, so that's the gluteals and tensor fascia lata. Let's move on to piriformis. So piriformis is one of the deep lateral rotators of the hip. So, and it's like the biggest and strongest of the deep lateral rotators. Let's get rid of gluteus medius. Oops. Okay. So piriformis. Piriformis is this muscle right here. There's a nice picture of it in your book. It attaches to the sacrum, the lateral aspect of the sacrum, but when we just saw a muscle that attaches to the lateral aspect of the sacrum, what was it? It was gluteus maximus. But gluteus maximus attaches to the posterior aspect of the sacrum. Piriformis actually attaches. Let's get rid of some muscles. Oh, I just got rid of piriformis. Okay. Let's do this. Piriformis. Let's bring it back up. And let's fade other things so we can see piriformis. So see piriformis here? Here we can see it from a posterior view. It attaches to the lateral aspect of the sacrum, but it is the anterior aspect of the lateral aspect of the sacrum. And then it crosses the hip posteriorly and attaches to the greater trochanter of the femur. Okay, so what does this muscle do? It laterally rotates the thigh at the pelvis, or at the hip. At the hip. So just like we saw gluteus maximus doing, just like we saw the posterior fibers of gluteus medius and gluteus minimus doing. So it laterally rotates the hip. And of course, that also means that when you're standing on that leg, and that leg, let's say the one we're looking at here, the right leg, if that is planted and stable, and the other leg is off the ground, and you want to turn your body, say, because you're walking along and you're standing on your right leg here, and now you want to turn to go this way, it's piriformis and these other lateral rotators that are going to rotate your body around like that. By essentially what they're doing is lateral rotation of the thigh, but if the thigh is planted, then that turns the whole body. So that is the main action of piriformis. And that is what piriformis does when the thigh is extended. So what we're looking at here is the thigh in an extended position. When the thigh is flexed, we have a completely different game that happens. So imagine here that the thigh is flexed. So we have the pelvis, we have the hip here, and then we have the thigh in a flexed position. So when that is the case, piriformis, and this is like, you're just going to have to try this on your body because I can't move the model, but other than to rotate it. But when that happens, the ischial tuberosity is going to, the attachment, sorry, not ischial tuberosity, I meant to say greater trochanter. The attachment of piriformis on the greater trochanter kind of rotates, and it doesn't rotate. It's hard to describe on this thing that doesn't move. But anyway, you'll at least just need to take my word for it that that what happens when the hip is in a flexed position is that piriformis then does horizontal abduction. So horizontal abduction, remember what that looks like. So horizontal abduction only happens when the thigh is flexed anyway. So it's moving the thigh away from the midline of the body, so in a direction kind of like this, but it's, with the thigh in a flexed position. So horizontal abduction. So imagine you're laying on your back and you have your knees up, right? So the knees are like pointing to the ceiling. And so if you let the legs drop out to the sides, that is horizontal abduction, or horizontal extension is also called. So that's an action that piriformis does. Now, in a position like that, gravity really is doing it, and and piriformis doesn't have a lot of work to do. But the reason I point it out like that, with imagining that you're laying on your back and your legs are going out to the side, is that would be the action of piriformis. Therefore, the opposite action of that is how we would stretch piriformis. So again, imagine you're laying on your back. You have, let's say you just have your right leg up, like knee to the chest, but maybe not quite that high. So it's more like your thigh is at a 90-degree angle. And then if you take that knee and cross it across your body, so it's crossing midline and moving over to the left side, then you'll be stretching piriformis, and that is a great way to stretch piriformis. And those positions with a patient on their back with their hip flexed like that, those are the positions we have somebody in, both to stretch piriformis but also to do tests often to see if piriformis is inflamed. And why do we care if piriformis is inflamed? Well, actually, for an important reason. So if we add nerves on here, we see a pretty significant nerve right underneath piriformis. This, not only is it pretty significant, it is the largest nerve of the body. It's the sciatic nerve. So the sciatic nerve comes out from the pelvic region directly under piriformis, except for in about 10% of the population in which the sciatic nerve comes through the piriformis muscle. It actually, goes right through the muscle. So most people, though, it goes underneath the muscle. So imagine if piriformis was inflamed or irritated or even hypertrophied. So you're doing something to build muscles, and that muscle gets bigger. And so if it's big and if it's strong, and if it's inflamed or if it's chronically tightened, what it's going to do is put pressure on the sciatic nerve here. And that, my friends, is called piriformis syndrome. And piriformis syndrome is often misdiagnosed as sciatica. True sciatica is when the sciatic nerve, or the roots that will come together to become the sciatic nerve, they are impinged up here in the low back region. That is sciatica. But we're going to get sciatica-like symptoms if piriformis is inflamed, and that is super duper common. And so knowing how to stretch piriformis and knowing how to do tests on piriformis help us to be able to decipher whether the sciatica-like symptoms are coming from piriformis putting pressure on the sciatic nerve, or whether it's coming from the low back, if it's true sciatica. So being able to release piriformis is going to be key if somebody is having these sciatica symptoms. So what are sciatica symptoms? Is a nervy pain, very often pain, numbness, tingling. It could be pain in the buttocks region, right, where piriformis could be putting pressure on the sciatic nerve. It could be pain running down the leg, along the length of the sciatic nerve. And so, but if the pain only goes to the knee or doesn't go past the knee, likely is piriformis syndrome. Very often with true sciatica, where the impingement is happening up here, we're going to get symptoms all the way down and into the foot. So anyway, so the sciatic nerve and piriformis have a very important relationship with each other, and a tight piriformis absolutely can put pressure on the sciatic nerve. Okay, so let's see. So main actions I want you to know for piriformis are lateral rotation of the thigh at the hip, but know that is also contralaterally rotating the pelvis, or the whole trunk, the whole body at the hip joint. If you're standing on say the right leg and you're turning to the left, that's piriformis doing that. And then horizontal abduction is a key action of piriformis. And so if horizontal abduction is the action of piriformis, then you're going to stretch piriformis by doing horizontal adduction. Okay, so piriformis is one of the deep lateral rotators. It is the biggest and strongest of the deep lateral rotators. The rest of the deep lateral rotators, I just kind of want you to know where they are and roughly, what they're up to. So as a general group, the attachments for the deep lateral rotators, their proximal attachment is the pelvis, and their distal attachment is the greater trochanter of the femur, basically the medial aspect of it. So let's see if we can see some of these guys. Okay, so we have the superior gemellus, and we have this is quadratus femoris. Okay, superior gemellus. Let's do this one. Obturator internus and quadratus femoris. So these are three that we can see here. And then, let's see here. Okay, then we have obturator externus. Obturator means that it covers up. So it's covering up this obturator foramen here in the pelvis. So this is obturator externus. Okay, that's obturator externus, and then a bit ago we saw that's quadratus femoris. Obturator internus here. Oops, I grabbed the wrong thing. Oh my goodness. Obturator internus. And then we saw the superior gemellus. There's also an inferior gemellus that I'm not seeing here, but it exists, and it's also right in through here. It's like in through here. Okay, so those are the deep lateral rotators of the hip. So deep lateral rotators, what are they doing as a group? Well, if we're not standing on the leg of the muscles that we're looking at, they're going to laterally rotate the thigh at the pelvis, or at the hip. If we are standing on it, they're going to contrarily rotate the pelvis. So that's what the deep lateral rotators do. Okay, next up we have the muscles of the pelvic floor. Okay, to look at the pelvic floor muscles, let's first orient ourselves here a little bit. Okay, so we're looking at a female skeleton, and let's zoom into the pelvis, and we're looking at the pelvic floor. So we're going to take a look from below. Okay, so first of all, let's find our bony structures here that are kind of defining this area that we're looking at. So we have the ischium, and so specifically what we're looking at is the ischial ramus. and the inferior pubic ramus here, that stretch of bone along there. This is the pubic bone, and then here we have the sacrotuberous ligament. So the sacrotuberous ligament runs from the sacrum to the ischial tuberosity. That's where its name comes from, sacrotuberous. So we have the sacrotuberous ligament. So you can see that the ischial ramus and the sacrotuberous ligament are making most of these two sides of the majority of this sort of diamond shape that we're looking at here, that is the pelvic floor. I'm going to try and tip this just a little more if I can. No, that's all we can do. Okay. We have the pubic symphysis, that's the disc in between the two pubic bones. We have, on this end, we have the, this is indicating the ligament. We have the coccyx. Let me get rid of there's the coccyx, okay? So, but you can see now that I took the connective tissue away that this looks pretty different. So we really need to have the connective tissue there to have a sense of this, the structure here that these muscles are attaching to, these pelvic floor muscles. Okay, so, and now there's this structure, but now let's just switch this up a little bit and take a look at the male pelvis. So male pelvis, of course, we're going to expect to see some differences. And okay, it doesn't look hugely different. Let's go back. But it is different. Here's the female pelvis. So essentially what we're looking at here is the pelvic outlet. So the space that something, this, what I had drawn here, this essentially is the pelvic outlet, right? So this is the space that something has to pass through to exit the pelvis. So on a female pelvis, this is what it looks like on a male pelvis. It's smaller, right? So the coccyx is more kind of tucked in. The whole area is smaller. So we have something kind of like this. And so we're going to see some significant differences in the muscles, partly based on the structure of the pelvis, because the pelvic outlet in a male pelvis is so much smaller. The muscles have much less distance that they need to span. And then, of course, there are other structural differences, too, that we'll see when we put some muscles on here. So this is a male pelvis. Let me just put one more layer on. So we can see right away, we can see some structures here. We'll go through these muscles, but we can see some structures here that clearly are in the shape of a penis, right? So we have other soft tissue structures associated with the pelvis that are very different on a male pelvis and a female pelvis. So these muscles, so ischiocavernosus and bulbospongiosus on a male pelvis are this shape. Now look what happens when we switch to a female pelvis. Where'd those muscles even go, right? They're still there, but they look really different. So anyway, we're going to go back and forth between the male pelvis and the female pelvis to get a sense of what they both look like. The significance of the muscles of the pelvic floor, very rarely would you be palpating them in your practice, but of course you may be needling in this area. So we have Ren 1 and Do 1 right in this area. And what else? And so people who have any sort of prolapse going on, and prolapse would show up in or may show up with a spleen chi sinking, sort of a pattern. We're going to see some weakness in these muscles, and so it could be a rectal prolapse, it could be a uterine prolapse. But if organs are, especially pelvic organs, are dropping and shifting position, you can bet that there's some weakness in these pelvic floor muscles. And we can strengthen these pelvic floor muscles pretty easily by doing Kegel exercises. So Kegels are exercises where we're contracting the pelvic floor, and that is definitely, Kegels in Chinese medicine are considered to stimulate kidney energy, but also they're going to help to lift spleen too, because the spleen chi should ascend. And if it's not, that's when we get dropping in the pelvic floor. So, okay, so let's take a look at some of these muscles. So in your book, page 718 has a similar view to what we're looking at here. It looks a little bit different. So on this, I can't take the legs off, and I can't move their position to give you a better view, but in the book, there's a little bit of a better view because the legs are out of the way. But we can see the muscles here that we need to see. Okay, so let's start with, so we can kind of divide the pelvic floor muscles into two parts, this being our dividing line. So we can look at the muscles that are anterior to this line, and we can look at the muscles that are posterior to this line. So let's start anteriorly. So our first muscle here is ischiocavernosus. So it attaches to the ischium, and and this is one that looks quite different in the male pelvis versus the female pelvis. If I turn it just a little, let me indicate this one. There's ischiocavernosus. If we fade other things, we can kind of get a sense of where it is. But basically, it's going right along the edge, the bony edge of the ischium there. If we switch now to a male pelvis, ischiocavernosus is still going right along the edge of the ischium, but is also somewhat wrapping the base of the penis. So it's a little bit different, differently shaped in between the male and the female pelvis. Okay, let's get rid of that fade. Okay, so that's ischiocavernosus. That's one muscle. And let me say too, with these pelvic floor muscles, kidney yang has a lot to do with these guys, right? Because kidney yang controls the opening and closing of the three lower yin, so the opening and closing of the anus and the urethra, or the lower yin. I guess it's 3 in women and 2 in men. So with a kidney yang deficiency, we would expect to see some weakness or lack of qi in these muscles. So anyway, ischiocavernosus is our first one. Let's go back to the female pelvis and look at this muscle. Oops. Okay, sure. This muscle, which is bulbospongiosus. So bulbospongiosus wraps around, in the female, it wraps around, you can see here, the vagina here, or the outer opening of the vagina, and the clitoris here. And so, and then now if we switch to a male pelvis, we're going to see bulbospongiosus essentially wrap around. Can you tell what muscle that is? It's, let me fade the others. It wraps around the base of the penis. So bulbospongiosis is a muscle that actually during orgasm spasms, and that is part of the experience of an orgasm. So it's mostly a muscle that has to do with sexual activity. Let's look at, going back to the female pelvis. This next muscle is called the deep transverse perineal. The deep transverse perineal is, as you can see here, I'm not sure if I can get rid of a layer. No, and show it just by itself. Let's bring it back. Okay. Oh wow, when I brought it back, another muscle showed up. And so it's this one that's a sphincter that's just around the urethra. And it wasn't showing before. That's interesting. Anyway, so that's the external urethral sphincter. Remember that a sphincter muscle is a round muscle that that when it contracts, it closes. When it relaxes, it opens. And so it controls the passage of fluids through, like we have sphincters throughout the GI tract, for instance. And so here, we're going to see, this is the external urethral sphincter. We're going to see a sphincter associated with the anus as well. Okay, back to the muscle I was talking about, deep transverse perineal. So this is one that spans that whole anterior aspect of the pelvic floor. This is one that that can get torn or stretched during childbirth. So you can see that there's an opening in it for the vagina. And so this is one that after childbirth needs to re-strengthen in order for a woman to feel like she's got control over urine and and just sort of integrity of the pelvic floor again. And so, remember, of course, during childbirth, there's a lot of opening that happens. And so these bones here that are making this bony structure of the pelvic floor, they're going to move away from each other. So, that whole softening and opening of the pelvis, that right there is going to cause some stretch to this muscle. But then when the baby actually passes through, then that muscle really needs to get out of the way for that to happen. Okay, so let's see. So deep transverse perineal in the female pelvis. Let's look at it in the male pelvis. So you can see it looks like a much smaller muscle in the male pelvis because there's much less distance to span. Rarely do men have a situation where they feel like they don't have integrity of their pelvic floor because the pelvic floor is so much smaller and because there are never babies passing through it. But you can see this is a significantly smaller muscle because it's a much less of a span across that pelvic floor. And again, let me see if I can take some muscles away. Not really. And show that muscle by itself. Okay. So that's deep transverse perineal. Now, if there's a deep transverse perineal, probably there's a superficial transverse perineal, right? And that muscle is right here. Superficial transverse perineal. So it is superficial to the deep transverse perineal. And it is the dividing line between the anterior pelvic floor muscles and the posterior pelvic floor muscles. And so it actually attaches to a structure. Let me see if we can see. Oh, I don't think we can see it on here. You can see it in your book, though. I'm going to switch to the female pelvis. So yeah, they don't really show it here, but there's a structure essentially right here, and it looks, kind of like that, like a square. It's called the perineal body. And so the two, and so it's like this central attachment point for these pelvic floor muscles. So for instance, when you do Kegels, it's that perineal body that's going to lift up. And when these sphincter muscles, or when the muscles of the pelvic floor relax, that perineal body is going to drop down. So, similar to that idea in the diaphragm of the central tendon that drops down when the diaphragm contracts and rises up when the diaphragm relaxes. So it's kind of like that. It's this sort of central attachment point. So that's called the perineal body. And again, you can see it in the diagram in the book. Perineal body. Let's see if I can write it here. Perineal body. Okay, that's that structure right there. So it's a connective tissue attachment point for these muscles. Okay, so the muscle we're looking at here again is the superficial transverse perineal. And this is it in the female pelvis. This is it in the male pelvis. Again, a much smaller muscle in the male pelvis. And you can't see the perineal body, in this, but anyway, it's there. Okay, so now let's look at the posterior pelvic floor muscles. So let's go back, I guess, to the female pelvis, where things are a little more open and we can see things. Okay, so this is levator ani. So levator ani, what levator means is lift or elevate, and ani refers to the anus. So levator ani is not the anal sphincter, but it's essentially the equivalent to the deep transverse perineal in the anterior part of the pelvic floor. It's going to, lift and kind of hold up the whole posterior aspect of the pelvic floor muscles. So that's levator ani, and so we're showing the iliococcygeus part. And so in some sources, we're going to see this just called iliococcygeus, but is part of the levator ani muscle. So it helps to lift the anus, and in doing so, really, it's like lifting and supporting the whole, the anus and the rectum. So this would be a muscle that if there was rectal prolapse, we would expect to see like overstretch or weakening in this muscle. So this is levator ani. Let's look at it in the male pelvis. And there it is in the male pelvis, not terribly different in the male and female, but yes, shaped slightly differently. Okay, so now let's look anterior to that. oops, that's not the one I wanted. There we go. This is also levator ani. This is the pubococcygeus part. So pubococcygeus is implying that it attaches to the pubic bone and to the coccyx, which if we fade things, we should be able to see that. There we go. Yeah, we can see that. So we can see that it's attaching up here to the pubis. It's attaching back here to the coccyx. So it's really spanning anterior and posteriorly the whole pelvic floor. And actually, in this faded view, we can get a better sense too of the iliacus part of the levator ani. So let me fade things. And so we can see that this is attaching to the ilium here and then to the coccyx back here. So that's where its name comes from, iliacus, and the other one was pubococcygeus. So they're both part of the muscle called levator ani, which just means that it lifts the anus. And let's switch to female pelvis and take a look at, I'm back on iliacus. Let's look at, here's the pubococcygeus part on the female pelvis. Nice kind of hefty, strong muscle to lift that whole, or to, span that whole distance of that large pelvic floor in the female. Okay, and then our last one here is the external anal sphincter. So here's another sphincter, this round muscle that opens and closes to allow passage, and so in this case, passage of stool through the anus. So let's see, let's fade it and just see what else we can see here. Oh, it looks about the same. Okay, so there's the external anal sphincter in the female pelvis. Let's look at it in the male pelvis. Looks much smaller, but actually there's more. Oh no, that's levator. Oh, that's another part of the levator ani. It's the puborectalis part. So anyway, levator ani, I'm happy to have you just know it as levator ani. There are, as you can see, various parts to it that are harder for some reason to indicate the separate parts on the female pelvis. But anyway, but what I'm trying to show you here is the external anal sphincter. So the external anal sphincter is attaching via a tendon or a ligament. I don't know, maybe it's a tendon. I don't know. I don't think I can indicate it by itself, but to the coccyx here via that tendon, and then here to that perineal body. Okay, so that's going to open. That's the skeletal muscle. In other words, the voluntary control aspect of the anal sphincter. There is also an internal anal sphincter that is involuntary because it's made of smooth muscle. Okay, so back to the external anal sphincter in the female pelvis. Okay, so those are the pelvic floor muscles. Let's see, anything else to say about those? I don't think so. I think that's pretty good. So 2 more muscles to talk about on this video. The first one, so we're still on a female pelvis right here. So our next muscle here is psoas, and if I fade everything else, can we see it? Yeah, we can. So the psoas is one of these deep, deep muscles that hardly ever gets touched, and when you do touch it, it feels horrible often. It's a kind of a strange, deep feeling. So it's a really interesting muscle. This is in bipeds, like humans, and other primates that are more or less upright. It's a muscle that gets worked a lot. In quadrupeds, it hardly gets worked at all. It's there, but it hardly gets worked at all. Therefore, it's very soft. And so, if you were to eat the meat of a quadruped and you're eating that muscle, it's what you would call the tenderloin. And it's tender because it doesn't get used very much in a biped. So you can imagine if this was a biped. So in a quadruped. In a biped, we see that the hip is extended, right? Whenever we're upright, walking around, the hip is extended. If we were looking at a quadruped, we'd have something more like this. The spine, it would be here in relationship to the hip, and so psoas would be down here like this, and in in a much more in a shortened position, and it doesn't have to work as hard at all in a quadruped. So that's why it's tender. In other words, tenderloin in quadrupeds. So like, anyway, okay, that's enough. Moving on to what else do we need to talk about with psoas? Okay, so psoas, there's psoas major and psoas minor, and but we're just going to look at psoas major. Psoas minor just I don't even see it on here actually, but it just sits. It kind of is right. It's just a skinny little thing right on top of psoas major. That's about where psoas minor is, but essentially they work together. So we're just going to talk about psoas major. In other countries and other languages, they pronounce psoas psoas. They pronounce the S. In the U.S., we tend to just call it the psoas. And so it attaches on the, let me get rid of some of these muscles and let's see where, there we go. So attachments for psoas. It attaches on the anterior-lateral lumbar spine. So specifically, it's on the bodies of T12 to L5 and the intervertebral discs, but it's tucked kind of back in the corner of, so it does attach to the bodies there, but also to the transverse processes. If we turn it around, maybe we can see that. Let's unfade. That didn't really help us that much, but anyway, you can kind of get a sense that it attaches to the transverse processes also. So the bodies and the transverse processes. So bodies of T12 to L5 and transverse processes of L1 through L5. So that's its attachment up here on this end. And then down here, it attaches to the lesser trochanter of the femur. So actions for psoas. Psoas is the prime mover in hip flexion. So we use psoas all the time when we do hip flexion. And the most common thing that we're doing when we're doing hip flexion, so this is hip flexion, we'll be moving the hip in this direction, is walking. So when every step that we take, we're going to contract psoas to lift the thigh and move the leg forward each time we take a step. So it is prime mover in hip flexion, and it also initiates hip flexion. It actually, though, gets stronger in hip flexion the higher you raise the leg. So it's not very strong down here where it initiates it, but once we get up into here, it gets stronger. And that's part of a product of that being a biped kind of thing. Our psoas is always sort of in a more stretched position. And so a muscle in a stretched position is not as strong. So that's why it's not as strong at that very first part of beginning hip flexion. So prime mover in hip flexion. The flip side of hip flexion is an anterior pelvic tilt. So it can pull forward on the lumbar spine, which then creates this anterior pelvic tilt. So hip flexion and anterior pelvic tilt. Now, it's a little bit of a complicated muscle based on what is being stabilized and what is moving, and also based on what position the hip is in. But another action of psoas is lateral rotation of the thigh at the hip. So we're going to pull here on the lesser trochanter, and that's going to rotate the thigh around laterally. So it does lateral rotation of the thigh. And it also, so if the thigh and the pelvis are fixed to each other, if everything is fixed, let's say, and psoas contracts, and so what we have is essentially just this big shortening of this muscle. So it's, so all the fibers kind of move to each other. We're going to actually get a posterior pelvic tilt with that. So with an anterior pelvic tilt, like I was talking about before, an anterior pelvic tilt is happening when there's movement at the hip, and the lumbar spine comes forward. That creates an anterior pelvic tilt. But if everything is fixed and we just move both ends of the muscle toward each other, more or less in an isometric contraction, then we actually get a posterior pelvic tilt happening. So you can start to see here that psoas is a key muscle in low back stuff, because it has everything to do with what position the lumbar spine is in. If the lumbar spine has too much lordosis to it, if it's too forward, if it's too much like this, that has to do with psoas. If it's too flat, or back like this, that has to do with psoas, right? So so a lot of people are walking around with a tight psoas. It's very, very common. And then when the psoas is tight, there's both a limited mobility in the low back, and then things can be structurally held in a less than ideal position, and so we're moving from a place that isn't ideal for the placement of those bones, as far as moving from there, and then flexion and extension happening from whatever position they're in. So, okay, back to actions of psoas. So, flexion of the thigh at the hip. That is the main thing to know about psoas actions, flexion of the thigh at the hip. It does both anterior and posterior pelvic tilt, and it laterally rotates the thigh at the hip. So those are the main actions you need to know about psoas. Let's see. Anything else about psoas? Okay, I think that's good. Let's talk about our last muscle here, which is iliacus. So sometimes you see psoas and iliacus as a group called iliopsoas. And that group iliopsoas has to do with the fact that these two muscles form a common distal attachment here at the lesser trochanter. So they are separate muscles, but they work very much as a group. The difference between them is that psoas attaches to the spine and iliacus does not. So iliacus only crosses the hip, whereas psoas crosses the hip down here, and it also crosses, it crosses all of these spinal joints as well. So iliacus, where does it attach? Iliacus attaches to that the inner aspect of the ilium. So it's the in the book is listed as the internal ilium, but it's that iliac fossa. Let's fade other things here and see if we can see that. So it fills in that whole anterior aspect of the ilium. And then it's going to cross the joint. Oh, let me say this one thing too about both of these muscles, that to get to where they're going in the thigh, to the lesser trochanter, they pass under, I can't get it. There it is. They pass under the inguinal ligament. So the inguinal ligament is a ligament that goes from the anterior superior iliac spine to the pubic bone. And so you can see the inguinal ligament there, and you can see that these two muscles pass under that space that's created by the inguinal ligament. Okay, so they're passing under there to get to the lesser trochanter. So and then you can see that lesser trochanter attachment there for iliacus. So iliacus is going to have very similar actions to psoas, except for the fact that it only affects the hip. So it's going to do hip flexion. And so I had said that psoas is considered prime mover in hip flexion, which is true. But if we're considering these muscles as a group, then we would say that iliopsoas, the group, is prime mover in hip flexion. But if we're separating them out, then we would say that psoas is prime mover in hip flexion. So it flexes the thigh at the hip. That's one action of psoas. If it does that, it also does an anterior pelvic tilt. So that just depends on which end of the muscle is moving. If we're going to move the pelvis and have the thigh fixed, we'll get an anterior pelvic tilt. If we're going to fix the pelvis and move the thigh, then we're going to get hip flexion. And then the other action is lateral rotation of the thigh. So is pulling up on this lesser trochanter. If that gets pulled on by the muscle, we're going to rotate the thigh around laterally. So that's the other action for iliacus. Okay, so that is it, my friends, for video 21. Oh wait, let me just double check that this is video 21. Yes, okay. That's it for video 21. We talked about these major hip flexors, iliacus and psoas, two major important hip flexor muscles. We talked about the pelvic floor muscles, which look different, but on male and female pelvis, we can see a couple of them there. We can add some more. Oh, they might disappear if we add. Yeah, they disappear. But anyway, pelvic floor muscles we looked at, and what else did we look at in this video? We looked at the glutes, and we looked at the deep lateral rotators. And so some deep lateral rotators we can see in through here. If we add on some more muscles, we can see more deep lateral rotators. If we add on more muscles, we can see piriformis, very important, strong, deep lateral rotator of the hip, and then the gluteal. So gluteus medius, deep to it is, oops, no, let's fade it to see gluteus minimus underneath there. And then, of course, we talked about gluteus maximus. Okay, so that's it for video 21. And then next up in video 22 is bones of the lower leg.